right, I'm going to plunge into tonight's support group. It's the 1st of July. We're following on from our ASCO 24 presentation, and we thank Bayer, Johnson & Johnson, Myriad, Telix, Foundation Medicine, and as usual, I forgot one. Who did I forget? Captain Jim?
Novartis.
Novartis, thank you very much. And we don't have any new folks, and we have an average room. I say we have an average room because I see 36 people, and that's pretty much where our average has been this year. Although our recordings, as I think I mentioned once before, are way, way up. And they'll probably get even more now that all of you can find where the recordings are again. I see something from Sarah Alley. Please unmute. And are you new to the group? You'll need to unmute. Okay. I see you responding in the chat window. Would you like time to talk to us? Okay. Well, we usually give new people a bunch of time, and we'd be happy to give you a bunch of time. But when you're ready and you can talk, if you'd like the time, I just want to make sure you did want the advanced prostate cancer group. That was the group you were looking for. I'm reading the chat window, folks, because I'm getting a response. So this is the advanced prostate cancer group, and I just want to make sure that's what you were looking for. Please, you're welcome. The visual snow group. The visual snow group. Welcome, Sarah. You're in the wrong room. We will put it's starting right now, and let me put the link to that room in the chat window for you right now. You can just go over. You can go over there. Okay, there you go. There's the group. That group is happening right now in that room. And for those of you who are wondering what visual snow syndrome is, it is a condition that affects about 3% of the world population, and you see the world just like through the static of a TV screen from when you were kids, when you switched it on. And we are debuting tonight a new group for visual snow syndrome in our Schmear room. And we're hoping it will be very, very successful. So I may have to repeat that if we get people coming into the wrong room again. Okay, we're ready to advance on our group, and we are going to start with Norm Pollock.
Well, I just had I found something that really helps with the hot flashes. I haven't found anything at all, and it's called Monostat. I'll put it in the chat. It's Monostat Chafing Relief Powder Gel. It's like Brill Cream, a little dab. You have any of it? It almost feels like a silicone. It's dimethicone, I think. Works great. It just takes all your chafing away. You can get it at most of the CVS and Walmart, but I'm real happy with it. That's all I had.
Oh wow!
What's the name of it?
I'll put it in the chat. It's called Monostat Chafing. Oh, I'm backwards. Monostat Chafing Relief Gel. I'll put it in the chat for you.
Okay.
Works great, and you hardly need just a little dab on your finger, and it smears real well. And it dries instantly. It feels like you got powder on, and no powder everywhere. So
Um,
try it. You'll like it.
Captain Jim, did you want to comment on that?
Yes, you say to smear it. Where would you smear it? And I'm not
Where do
trying
you
to
get your
be rude
chafing? Where do
either.
you get your chafing? So,
Oh, the wait
I
a
get
minute.
armpits and groin. That's wherever you're chafing.
But what happens if you are not chafing and you're just having the hot flash? You
Well, it
stick it on
doesn't do
your
anything.
forehead, or you?
It's just for chafing. It doesn't.
Oh, it's for chafing. I thought it
Yeah.
was for to stop the hot flashes, and
No.
I
Well, see,
was curious where you might rub this stuff. Okay, I got it.
Okay.
I
So
tried
this,
snorting it, but that didn't work either. I don't know. It's just, yeah. I mean, I sweat with my hot flashes, so I chafe a lot.
uh, so this is for if your hot flashes are causing you chafing,
Right.
this is a solution.
Yes.
Got it. Okay, well, thank you. I'm again very grateful that you shared that. Any questions for Norm on this? He's going to put the name of it in the chat window. I think he's doing that right now. Any questions for Norm on this? Okay, so going down the line, and hopefully we're going to have a lot of shorties like this, which is great. Richard Fisk, what's on your mind tonight?
Yes, sir. Um, just went over month 20 of 24 months on hormone therapy, and talking with my um, hematology oncology doc, he talked in terms of something on the order of graduation from the program, and I'm going to get booted back over to a urologist to have my PSA monitored periodically. Is this appropriate?
Um, so you're being treated at Belvoir, are you not?
Yes.
Um, well, my recommendation would be since you must have TRICARE, or do you have TRICARE or TRICARE for life? Do you not?
I care for life.
Yeah. So my recommendation, and I'm going to allow Captain Jim to speak when I'm done, is my recommendation would be to bring on board a GU medical oncologist and not depend on Belvoir
Okay.
because they're not, and also hopefully General Joel will have something to say about this too, and we'll open it up momentarily. But my suggestion would probably be in your area to book an appointment with Dr. Channing Palla at Sibley. She's a very smart, affable GU medical oncologist who knows her stuff. The choices in the DC, greater DC area are not terrific. And if it were me, I'd feel comfortable in her care. But let me start with Captain Jim.
Well, can you spell her last name, please?
I'll put it in the chat window, and I'll put
Okay.
a link for her. Her name is Channing Paller, Paller, and I'll put something in the chat window whilst these guys are talking. Go ahead, Captain Jim, please.
Richard, are they talking about now? Are you going to go essentially on a treatment holiday, or how is this supposed to work?
It's when I complete the 24 months of ADT, I stop the medication. So yes, a treatment holiday.
So it'll be a treatment holiday. So you will go on to probably PSA testing every 2 months or 3 months.
Hopefully, yes.
And the thing I would suggest is also testosterone, test 2.
Okay.
And yes, hook up with a GU type. Now, I
Okay.
don't know how come they are kicking you over, but I would not be surprised in the military.
Well, it was uh, the sense I got was that I was completing the program of um, the ADT with this doctor, and once I complete that, then he doesn't need to follow me anymore because all that is necessary, he says, is periodic PSA tests. And I said,
So, so you weren't declared stage 4 in the beginning. You were like stage 3 or something like that.
yes,
Ah, okay.
yeah,
Uh,
non-metastatic.
right. Dr. John, chime in here, please.
Oh, okay, Jim. Yeah, Richard has only localized disease, but he is very high risk. So if it was me, I would feel a little more comfortable having an oncologist follow me than a urologist. And also, the last time we talked, I think genetic testing was pending. I'd like to know if you got results back, and if so, what they were, because that might affect what we think about this question also.
Germline testing was completely was negative for the 48 tested genes.
Okay, thank you.
I think Rick is correct in Shining Prowler, but you got a couple of other options. You have two in Virginia. You have Argon Cheng at part of the Shore Center, and also Dr. Joshua Allen in the Shore Center, Innova Shore Center. Dr. Allen also closely works with Dr. Markowski at Johns Hopkins. So he
Right.
doesn't rely on only his own experience. If he has a complicated case, he shoots it to Markowski. So so that's a good team right there, I think. But so you do have some options.
Okay. All right. Well, that's good. How would you recommend anyone that I make that decision? Choose among them.
A lot of
I've
these
heard Dr. Paller give a couple of talks, and I think she's great.
Okay.
Does anybody here have Dr. Paller?
Gary Peters does, I believe, but he isn't here.
I'm here. No,
Oh, oh,
I
oh,
don't have her.
oh, okay.
I talked to her once, but I don't see her as a patient.
And the mechanics of that would be simply to, after I have my last meeting with my uh, current doc, just call and make an appointment and say, here I am.
Yeah,
Yep,
I
yeah.
think what you could do is look, a couple of things. First of all, we like centers of excellence, and Sibley is a center of excellence as part of Johns Hopkins. Secondly, for a whole number of reasons, which I don't want to get into, I personally am not thrilled with Aragon Chang. Um, I don't like ways she's handled a couple of people that we know have been treated by her, including somebody we lost recently. She wouldn't be my choice, and she's not at a center of excellence. Josh Allen seems to be a little better, and he has done a great job by our foamy gland gent, and he's worked closely with Makowski with the foamy gland gent, and it's been good. But Makowski is at Johns Hopkins. So, why mess around with the Share Center when you can go straight to Johns Hopkins. Now, how would I get to Johns Hopkins? I would probably tell them that you're a high risk. I would call them right now and say you're a high risk um, prostate cancer patient moving towards the end of your hormone therapy. You've been treated at a military hospital and you'd like to open up care. And I think with that, they would say, yes, we can get you in. If you have a problem, you can write to me, and I can drop Dr. Palla a line. I just had an email correspondence with her this past week around P10 and its presence in germline, and I'm sure that we can get you there. But I would just call them up and say, you're a locally advanced prostate cancer patient, and you're completing, and you want to you'd like her to follow you.
Okay. Very helpful.
Richard would be allowed to call himself very high risk, even though he's non-metastatic,
Yep.
just on the
Yeah.
basis of his Gleason. So if you want to sound scarier, you could say very high risk.
Okay, well, that's
Tell
what
him.
that's what 4+5 is, right?
Yep.
Yeah.
Tell him you're a Gleason 4+5, and you're coming towards the end of your treatment. Don't say you finished your treatment. Don't say you're off your treatment. Tell them you're still taking hormone therapy. And you'd like Dr. Palla to follow you.
Okay. All right. And so I'll take it from there. And if I have problems, I'll tell them I'll sick my big brother Rick on them.
That's right.
Richard, oh,
Go ahead, Jim Marshall.
Richard, you said you had germline, but you did not mention somatic testing.
Correct.
Did you have it?
No,
No.
but I
Uh,
intend to go back to the genetics people at Bethesda and ask if I can get that.
yeah, I'm not quite sure if it would go through genetics folks or it would go through urology, because usually I've heard it's urology initiates it, and genetics shall be the one that will speak with you.
Okay.
Richard, did you have surgery or did you have radiation or just hormone therapy?
External beam plus high dose brachytherapy.
Gotcha. Okay.
And testosterone and PSA have been not measurable for since the beginning, since I began treatment.
Great.
Another thing, Richard, at the time that you stopped this thing, I would be, well, the thing anyway I did was to get the test essentially every month, because it took me almost a year to get the testosterone to start up again. Actually, it was about 14 months. So immediately, I don't think it will start up again, but it was a good thing to know that it is starting and to start to track it. So I don't know if they will agree to this, or Channing might. I don't know.
All right. All right. This has all been very helpful. Thank you, gentlemen.
Okay, keep us posted. Please let us know where you finish up.
Yes, sir.
Okay.
Oh, another. Well, okay.
What?
There was another hand up for
Oh, there
Richard
is. Yes.
Series E.
Yes. Gary
Oh,
Z and then
no.
Alan Babcock. I was about to come to Alan Babcock. Babcock, thank you for pointing
Oh,
that out,
well, he could, I
Captain
mean,
Jim. So let's go to Gary Z first. What did you have to say on this issue, Gary?
okay, well, thank you. And I feel like I need to quickly preface, I've been MIA because I teach part-time in the evening, so I'm glad to be back after some time gone, and I am getting back to um, our most recent colleague in the comments, but I'm I admit to feeling a bit shaken, Rick. Um, I have been under the care of Aragon Ching since 2016,
Mm-hmm.
and this is probably something. It's probably better that perhaps I can exchange emails with you um, offline. I just suffice to say that um, I'm kind of shaken to hear that Shar is not considered a center of excellence. But I won't, as I say, let's have this
Okay,
offline. And
that's.
if
Can
I'll
I
just give,
hold
if
you?
I, yeah,
Can I
yeah,
hold you on? I'll come back to you, but can I hold you on the first part? Um, Shar is not a center of excellence. A center of excellence is a hospital that is NCI or NCCN accredited. So there's no, that's not a debatable. It may be a good center and they may run trials, but they're not a center of excellence. They're a community clinic. So I just want to be real. I just want to be real clear on that point.
thank you. I did not know that. Yeah. So really, the last thing, it's just my 20 seconds. I have a feeling, since I've been MIA, that Rick, you know this, but uh, Sean Collins is moving to Tampa, I guess, in September. Um, and just um, again, since I'm a little bit shaken, when he asked me who my urologic uh, or sorry, GU oncologist was, I said Aragon Chain. He said keeper. Anyway, um, I just got the letter a few days ago. I had spot treatment with Collins in February um, because Shar wanted to do 30 days um, of proton, and Collins had me 5 days on.
Time out,
So
Gary. We will come to you to talk about your issues,
okay,
but right now
so
we just want to
okay,
stick on your comments. I'm happy to discuss Aragon Cheng if that's what you'd like to discuss. I'm not concerned about discussing it in a forum. We do it all the time. If somebody just asked me about Dr. Kwan in the chat window. We are not fans of Dr. Kwan. Why are we not fans of Aragon Cheng? I'm sure she's a very nice lady. I'm sure that she is capable. But we've seen her in at least two people, if not three, that I can think of, where her treatment protocol for individuals in question has not been good. And if it were me, based on that and based on having seen her, I would not want to be treated by her. At the same time, she treats a lot of people. She has a very good reputation. But even up, I would go to I would go to a different doctor. There are doctors in many places that I wouldn't go to. There are doctors at Hopkins that I would not want to be seen by. And people come onto this forum to ask us what our opinion is. It's our opinion. It's other people beg to differ, but if I would not recommend somebody see Dr. Aragon Cheng um, for a bunch of reasons.
and your opinion matters tremendously to me. So I'm going to yield the floor. I'm sorry, I don't have anything more specific regarding our colleague who just updated us on his
Okay,
his
and we'll come
patient.
back to you for your issues.
Great, thank you.
Okay, I've got you on the list. And right now we don't have another go-to radiation oncologist in the DC greater area, but I'm hoping that some of my DC guys can come up with some good suggestions in lieu of Dr. Collins. We are aware, we've talked about it before. It's not great that he's leaving because he was a go-to guy for us. So, but if anybody has ideas, please let us know. Alan I know Captain Jim has his hand up, but Alan Babcock had his hand up.
Yep. So
Alan, did you want to say
just
something?
just real quickly there, Richard. I took my hand down because it sounds like he's going to go to a GU oncologist, but I just want to say I got the recommendation here to go to a GU oncologist, and it made all the difference in the world. I mean, all of a sudden I was talking to somebody who knew all kinds of treatment, who seemed to know so much, and he just put me at ease. The urologist, who I liked immensely, but he didn't put me at ease. But when I went to see Gainesman, it was like, all right, I can relax. And I'll thank
Yeah.
this group, thank Rick in particular. They headed me there. So that's what I
But
wanted to say.
that takes all the challenge out of it.
That's the way I like it.
Oh, thank you, Alan. I appreciate that input.
Yep.
And stand by, Alan, because we're coming right back to you. Captain Jim, you had your hand up.
Yeah, I was about to say, Dr. Collins is heading anyway to Tampa. And so all of you Florida folks will get a good one.
Well, here's the most interesting thing. He's
With
going
his
into
twin brother, right?
Yes, he's going into practice with his twin brother, and they're identical twins. So you might never know who's treating you, which is going to be very, very, very interesting. So we'll see what happens. Alan, you asked for some time tonight.
Yeah, just a real quick question. It's based on the research that we just heard. So I went and got my genetic testing through Color, that free thing. Now, and it all came back negative. So am I okay saying, yeah, that doesn't need to be redone, or no, I'm undetectable, but if it goes detectable, starts going up, should I be asking for genetic testing again?
So I'm going to ask for opinions from some of the professionals on here, but the color panel is 32 genes, and it is sufficient for Promise to be doing their research. There are other panels for germline inherited testing that are a lot larger, such as the Illumina panel. And certain genes are not tested, and one of those, for example, I believe is P10, because I noticed that the other day. Joe Blanchett mentions Invitae. That's another good panel and a bigger panel. My own suggestion to solve this problem would be, that's fine for now that nothing showed up. If, for example, you needed to do a somatic test down the road and P10 came up, I would probably say go to get another germline test just to make sure that the P10 is not germline. But P10 and RB1 are very rare. I think P10 is not on the color panel, but I'm not 100% sure. It might be. RB1, I'm pretty certain, is not on the color panel, but it's going to be on a more expensive panel. So if you have any of these and it could impact your offspring, you can get tested later on. It's not going to affect you any right now. Would one of the medical folks like to comment on that?
That makes sense to me, Rick. I can look back on the color panel and see if P10 is on there if you want while you're moderating.
Thanks. Yeah, that would be good. But you know, if it's good enough for them to do their test, I mean, it's good enough for me. It means that anything that isn't on their panel is probably going to be pretty rare.
Okay, thank you.
Okay. Any other comments on questions on germline versus somatic testing? Okay. All right. We're moving down the list and we're at Dan Straub, who I think may have had some meetings since we last spoke.
I did, and my urologist was pretty much slow walking the PSMA and then the CT scan, which indicated possible uptake in the liver. So they were a little concerned, but then that came out as a false positive. And I finally met with him last Wednesday, and I was not happy at all. And immediately Rick and Jim and Dr. John helped out. To make a long story short, Dr. Kim was shit canned, and I got a new referral to Dr. Iva Ferreira as an oncologist and met with her today. And I'm completely happy. She's going to take over everything. She's indicated I don't need a urologist at this point. And I have a meeting on Wednesday with the radiation oncologist, Dr. Nasser. It might be helpful to other people. He's with the Virginia Hospital Center. We'll see how that works out. But one of the issues I had with Dr. Kim, he was essentially shit canning the idea of a short, what would you call it?
Buffer.
No, that was the other issue. He did not want to do the buffer. He said I didn't need it. He was indicating I was getting too much information that doesn't apply to me. Essentially, he was blowing me off. And when I reported this to my primary care, and even before that, Kaiser set me up with another urologist. And over the weekend, yesterday on Sunday, I have a meeting with him next Sunday, which has been canceled. He essentially agreed. He just blew me off. It's only by talking to Iva, the oncologist, who's indicated she doesn't think it's necessary either, but it's a whole different comfort level that she's given, and I feel very comfortable in her hands. And essentially, she's put me on triplet therapy. So going forward, she's already been in coordination with Dr. Nasser, and as soon as I meet with him, I'll probably start treatment, radiation. The Lupron might come before or after, as she's indicated. She's going to work that out with him. But it's a whole different story than a week ago with Dr. Kim.
Okay. Well, we're glad to hear that. I still think that I would want to do a buffer. We're pretty big on the buffer only because the side effects are not that bad and it's a good insurance policy. But and it's commonplace. It's just commonplace everywhere.
I pushed pretty hard, and I think she was very kind in saying that my situation didn't require it. And my big fear was about the liver. And she said it's so small that the nodules they're seeing. And essentially, to address that issue, she's already scheduled an MRI to look at the liver situation. That's going to be the earliest I could get was March, but in August, but she's going to be on top of that.
Okay. Any comments in particular from Captain Jim, because he's our Kaiser expert in the DC area.
Oh no. Uh, I believe it's all good. It's all good with her. She is good.
Okay. And any other comments from anybody in this group about using a buffer before you start Lupron if you are de novo metastatic, even with lymph nodes?
Rick, I believe what they're claiming is he is not novo at all. Therefore, he doesn't need one. But provided he was, he would need a buffer. And
Yes.
I believe, and what the basis is, taking the PSMA test as an absolute 100% proof he is not. I would not agree to that. I would say there is a chance, and therefore give me the buffer because the pills are cheap. I mean, the pills
Yeah,
are a drop in the bucket.
yeah, yeah.
So it isn't a question of money. I think it's a question of somehow they believe that are not if you are not de novo, then you don't need it. So
Well,
it
I
seems to
can
be
only,
around in the Kaiser world now.
well, maybe it's because I was in the Kaiser world many years ago, but I mean, we didn't have PSMA scans, but I was 4+4 with a fair amount of disease, and they certainly gave me a buffer before I got 15 days of bicalutamide before I got my Lupron shot. Um, my understanding was it wasn't just the liver. I thought they saw some metastasis in some lymph nodes as well. Was that not right, Dan?
And they did find something in the pelvic girdle area. Right.
That's right. So, I mean, if you've got metastasis in the lymph nodes in the pelvic girdle, that's enough for me to say, the disease is out. You need a buffer. I don't know. I mean, I'll throw that open. Anybody else gone straight into Lupron without a buffer? Unless, of course, they've had an antagonist like Firmagon or Orgovyx.
The catch is the same way. I went into it without that. Okay, I was a 3+4, and it was like automatic with me. And the thing, if it was me, Dan, I would tell her that I feel very uncomfortable doing this, and I worry about this, and um, the thought of not having a buffer is then causing me anxiety
Ooh,
because
good one.
that's the big issue in all of the surveys they happen to send out. How do you feel about Kaiser? So
Hmm.
as I say, I would play the emotional card, and I believe she will bend.
Okay. Thank you. Any others?
Let me just say, this is John. If it absolutely comes down to they completely refuse, don't skip ADT because you can't get a buffer. I mean, fight for it as long as you can, but don't postpone or give up the ADT because you don't get a buffer. Just do it.
Right. That's where I was today. I got such a positive 180-degree different reading with her versus either Dr. Kim or Dr. Lee that I figured take the positive. You can always push back as you're indicating here. Um, it's better to make progress than turn everybody off. So
Sure, agree,
that's where I am today.
agree. But I love Captain Jim's advice of playing the anxiety card. I think it's a very smart suggestion.
Right. And she ended up saying quality of life because I asked her if I moved to a different part of the country and she was asking where I was, etc. She came right back and said quality of life is really important. You know, you can always come back here for your blood tests, etc. So I'll play that card next. Thank you.
I think you've got to give some very hard consideration to getting out of the Kaiser system when you get to switch at the end of this year. And I know a number of people who have done that once they've been diagnosed with disease similar to yours. It just is not set up in most cases, not everywhere. Jeff Marchi will tell you, um, but in most places, it's just not set up to handle advanced prostate cancer. They just don't have the right docs.
Right. I think I'm beginning to see that. I'm just so happy to finally get Dr. Eva. Um,
Right.
so it's a step forward for me where I am, and I agree with you. In 6 to 9 months, maybe it's a different evaluation, but for right
Yeah.
now, this is the
Yeah.
best that I can do.
Yeah. I mean, any doctor who tells his patient that they're overeducated is not my kind of doc.
Yes. We should be encouraging people to be not only knowledgeable, but be an advocate. Should be
Absolutely.
helping them. And then bedside manners never went away. I mean, you should not be essentially giving the feeling like you're ready to stab somebody in the back as soon as they turn around.
Absolutely. Okay,
Oh, Rick,
we're moving, we're moving along here.
Rick, it's
Um,
Larry. Can I say something?
yes.
Yeah, that's a very interesting point. I remember my first oncologist. I was pretty naive 9 years ago, 8 years ago, and asking him about revenge or something, and he's saying, you are talking about, ABC, and I am a PhD, and I'm telling you this. And now I could go back to him and say, you're a PhD, but I know more about this disease than you do, much more. And I'm so glad that was like the beginning of the end of our relationship with, in this case, whatever hospital. Not necessarily bad, but it was NYU Legon. And in their sites, they have some very bad oncologists. We're not supposed to speak negatively, but it was quite an experience. And he said, "You're talking ABC, and I am a PhD." And now I fuck you.
I think that we have to come up with some honor that we can bestow on our old time AnCanners. We can't call it a PhD, but maybe I'll put Dr. John on this as to what award we can give him. Jeff Marchi, who is a wizened Kaiser Permanente warrior, but from Northern California. What is it you would like to tell
Well,
Don
I
Stroud?
just a couple of things. Yeah, if you're in Northern California and can get Heart Stark, you're going to do pretty good as long as you can, ask for what you want. Because even with Heart Stark, I had to ask for darolutamide. I had to put a little pressure on her, but she went along with it just fine. And I think they have taken great care of me as well as any of the GU medocs I've heard people talk about here. But there is a real problem with leaving Kaiser if you've already got prostate cancer. And that is you probably can't get any supplemental insurance because they won't take you if you have cancer. They won't, you'll be able to get the regular Medicare, but if you go for a prescription supplemental or a medical supplemental, you're going to have a hard time if you can find it at all because they don't want somebody that already has prostate cancer. Other people there can comment about this, but that's my understanding what happens if you leave.
Well, So I switched. I switched plans. Now, admittedly, it was with a move, but usually you can switch between Advantage plans
Oh yeah,
without
yes.
having. So you can get a different Advantage plan, which isn't in Kaiser, which allows you to get to other docs that might be, you have to find out who their docs are. And the other thing you may be able to look at is what is your maximum out of pocket when it comes to that, so that you can make all the calculations. Um,
No, yeah, that's a
my
good point.
advice would
If you get
be,
an
my,
advantage, that's great. But if you can't get it, don't do an advantage. It may be a problem
yeah,
financially.
it may be harder to get into a supplementary plan, but my advice would be to work with a really good Medicare health broker. You know, you'll need to pull on board a an insurance broker who specializes in Medicare. But Jeff's point is well taken. Okay, we're going to move along if that's okay. And we're going to go to another captain in our group, Captain Frank Fabish.
A quick update, just for everybody. I was on Pluvicto for 2 treatments. My PSA went from 3 to 32 in 6 weeks. A PSMA showed that the cancer had had attached to the bones, and my doc now is recommending to change to a PARP inhibitor, and Rick had recommended my last somatic testing was about a year ago, that I get another sequence. So I put that request in, and I'm waiting to hear back from the doctor, and I expect I'll get that blood sample sometime the end of this week, beginning of next week. If it's positive, I'll move forward with he's recommending the, if I pronounce it right, olaparib in the PARP inhibitor, and with the BRCA2, if it's confirmed that it's still present, then that looks like the best choice to move forward.
Okay. Well, I think, I mean, you were one of the people that I had in mind when I did that BRCA presentation earlier on in the first half. As you can see, and you can mention to Dr. Mordasabi, it's not, it's rare, but it's not uncommon. I think there were 25 out of 400 people that they looked at in the Flatiron who reverted to wild type, and some of them reverted. I would bet dollars to donuts. Some of them reverted after doing Pluvicto, because we know that the reversion is accelerated by both chemotherapy and radiation. Pluvicto is a type. Pluvicto is a type of radiation, so it makes a lot of sense to just verify that you haven't reverted, because the last thing we'd want to see is putting you on a course of olaparib, which is going to may play heck, as you saw with your blood marrow and your blood counts, and you don't even have the mutation anymore. But if you have the mutation, it's probably real good. Now, the other interesting thing, which was in Len's slide, was the difference between the types of PARP inhibitors. We've long talked about that, going back to Professor Bill, God rest his soul, who was one of the people that had germline BRCA, 2 and it reverted to wild type, and he himself was a genetic researcher. And at that time, talazoparib was coming out, and we knew that talazoparib was 9 times more potent than the olaparib. Very interestingly, Len said today that it had 9 times worse effects, probably because it was 9 times more potent. Now, potency doesn't necessarily mean that it's going to be more effective, because the more potent it is, the less they give. You know, it's like a concentrated flavor. You know, you just put less of the concentrate in and you get the same amount of flavor. It doesn't, but you finish up with the same level. So, but olaparib works fine. But now you have rucaparib, olaparib, talazoparib, and a few other aribs that I can't remember off the top of my head. So, but let's make sure that you are where you are. Anybody else have anything they'd like to say to Frank on this issue? It's fantastic when we have living examples of what we're talking about, just because you guys see this isn't all in theory. It applies to so many. It applies to you guys. Any comments? Anything anybody would like to say to Frank?
Frank, it's John. I would, could you remind me what the trajectory of your PSA is in the last few months?
3 to 32.
And it's 32 still?
Uh,
Or did it
32
go?
was as of last week.
Okay, thank you.
And that was, John, that was all while I was on Pluvicto,
Pluvicto, right, thank you.
those 2 treatments.
And I don't see it. Oh, you have P10, right? Yeah, I do see it. You have P10.
Yes. Yep, P10 and BRCA2. And I think the other one that you mentioned is the PK.
I haven't talked a lot about. We didn't talk about PK today, but or PIK, but I've seen PIK before. I don't know much about it. I don't know quite where PIK fits in. Anybody? Anybody know where PIK fits in as a mutation? We'll have to do some research. Let's wait and see if it comes up. Okay. All right. Can I move on? All right.
Yes.
I see an interesting comment from Dan Straub. Dr. John says color includes P10, and Dan Straub says he just got his color genetic test back and it does not include P10.
I'm wrong. It does include P10. It does.
It does.
Right. I interpret it as P10 as a number, and it's PTEN.
Yes,
Sorry,
it is.
Sorry.
Okay. And what did your color test say? Do you have anything, Dan?
No,
You didn't update.
They found nothing of significance.
Okay, important. Thank you. I will make a note. Okay, it's now Gary Z's turn for himself. Gary Z.
Thank you.
Come on in.
So, just really quick, I go off of Orgovix at the end of this month. Been on it 6 months after having a 3-year vacation. I had the spot radiation with Sean Collins. I think it was March of this year. I just, as I was listening to our other our other what we call ourselves, the reluctant brotherhood, right? I found the packet that contains, since we're a lot of talk about genetic, I had the Inova oncology genetics, but that was way back. Just give me 10 seconds. Sorry. So first of all, there was no BRCA. This testing was done in September of 2019. Do I understand correctly that there's a whole lot more additional genetic testing now? And I'm not going to say any more, Rick and fellows. I'm just really glad that I can tap back in after being gone for what feels like maybe 3 months. And I don't really have anything else, to report. I just want to listen.
Well, I think my records would say the last time we talked to you or you spoke up was in January.
Oh my
So
God.
that's 6 months.
Oh my
Now,
God.
let me address your first question. Did you say you did genetic testing in 2019?
That is correct.
Okay. You don't need to repeat genetic testing in germline genetic testing.
When you said, I
So,
know germline has said this was Ambry Genetics.
right.
Okay.
And Ambry Genetics is a germline test,
Oh,
and you don't need to repeat that because that is a measure of what you have in your body. And it should stay the same at all times. It's not 100% true, as you heard tonight. Wild type BRCA actually occurred in men who inherited a BRCA mutation. So the germline can change. What would be interesting would be to know whether somebody who reverted could then pass on a mutated BRCA or whether they'd pass on a wild type BRCA. There's one for our brains trust to consider. You would think that if it's reverted, they can only pass on what they have at the time that they create a child, an offspring. What do you think, John?
I think that everybody in this room is past their reproductive years.
Well, wait a minute. Robert De Niro wasn't, and he got prostate cancer.
Yeah.
But Gary, basically, you don't have to repeat it. It's in every
okay.
cell in your body. What we're talking about with repeating is the somatic changes that you make. And most precision medicine today is looking at somatic changes, but not all precision medicine. So even the BRCA2, which is what we hear about all the time, it's often germline, but it's not always germline. You can make BRCA2 mutations yourself,
Okay.
and you can unmake them yourself in response to treatment. So just to be absolutely clear, you did 3 years of hormone therapy, is that right?
Yeah. Okay. So 2016, I had concurrent hormone therapy and 40 days of IMRT with Dr. Kanani at Inova Shore. I was clean for a year. PSA rose. I then, from autumn 2017, basically to the end of 2019, I started on just like Irgon Ching was using a 3-month injection. And maybe after 9 months of that, I said, hey, could I observe like 4-month interval? You're giving me a 3-month dosage. I want to I want to go 4 months. She said I'm comfortable with that. And that gradually went to like, okay, let's observe 5 months for a 3-month dosage. I then very early or very late 2019, I went to my urologic surgeon who did the radical prostatectomy. He said, why don't I'm suggesting you consider true intermittent approach, meaning go off it for a certain period of time. So I did, and I feel extraordinarily lucky. I was able to go 3 years until late in 2023 when it started to rise. And I've mentioned what treatment I've had so far this year. The only difference, February 1 through end of July this year, is that I'm taking the Orgovix instead of the injection.
And one of the things I see here is that you had to fight back in October of 23 to get that PSMA scan, and eventually you did get it, and
Yes,
and it showed an iliac.
yes.
But you've only ever been placed on, and correct me if I'm wrong, but you've only ever been placed on a LHRH drug, in this case Orgovix, and not on a second line ARSI.
That's true.
So again, this is another, I would say that's controversial.
I definitely know. I certainly remember in 2023, I attended many sessions here on AnCan, and yes, I'm aware there's lots of conversation about second line treatment. So anyway, I thank you. I'm listening. I value your opinion and Dr. John and everybody greatly.
So we're here, and if you do feel like you want to make the change at some point, we're here to support you. But we hope to see more of you. What do you teach,
Yeah,
by the way?
I teach music. I teach guitar, and yeah, it's unfortunately it's some Mondays, but it's usually more Tuesday and Thursday. But I think Tuesday is also one of our prostate AnCans. So it's really good to be back. I am going to read more about the I'm sorry, Panner, I think the Sibley hospital. And then, as I say, maybe some specific.
Okay.
I can email you or Dr. John, if at your
You can.
convenience. Yeah.
And you are what city are you in Fairfax County?
Yes, I'm in. It's Western Fairfax County.
Okay. Well, you do know that we have another guitar teacher in the DC area who's on this call tonight, don't you?
I do. I remember that. I'm sorry, I'm forgetting the gentleman's name, but he and I did converse a little bit on the.
Jimmy
Yes.
Greenfield.
Yep. I am aware of that.
Okay.
Guitarists, we're a dime a dozen,
Okay. Well, but not good guitar teachers like you guys, and I see a duet in our future.
Well, I also I write, and this AnCan has inspired me. I have a song idea, regarding my cancer journey, and anyway, I'll email y'all more later. Is that
You email that, and I just would like to say for those of you, all of you here, Solo Arts Heal, which is our joint program with the Marsh Theatre Company in San Francisco, which we've been doing now 3 or 4 years, and in which Jimmy has appeared. And if you go to Solo Arts Heal page on our website and go back to, I think, 2021 when we started, you'll be able to listen to the interview I did with Jimmy. And Jimmy was kind enough to produce another guitarist that I interviewed last week, Dan Dressen, who is one of our moderators in our active surveillance low risk group. We had a fantastic session. And
Excellent.
I can see us reaching out to Gary Zellner for a Solo Arts Heal
Oh,
sometime in the near future, because we're always needing guests for Solo Arts Heal.
thank you. I am interested. So, again,
Okay, that's
I will,
great.
I will look at Silhouettes. Thank you, everyone.
That's and Captain Jim. Next time you organize a DC get together,
Right.
you better have Gary and Jimmy bring their ukuleles.
Yes, absolutely.
I have a ukulele too. Yes.
Yeah.
There you go. Now you had something on your mind, Jim.
Yes. Okay. In Overshar, there is, let's see, I've been in their support group now for 3 or 4 years now. And historically, I see that Chang does not use the second level anti-androgen. And so the reason why I'm in it, because a lot of times I troll for folks that need us. And so I happen to look around, and I don't know if I recruited you,
Yes, sir.
Gary, out of there. Yes, there are a number of folks, but um, that's something I have seen historically for the last 2 to 3 years, and I kind of shake my head, but there isn't anything I can do except for try to get the folks over here to get a different view of things. So
Okay.
I'm
I don't
very,
know.
very grateful, Jim. You are the reason, I joined, which I think that was back in 2022. I'm sorry, I forget exactly, but
It's okay. My answer, my response is thank you, Jim. Thank you, Maestro, Gary Z, and we got you back. So we're going to move on, and we're going to talk to Dr. Jeff.
Thanks. So I just want to throw a couple of words of caution out there to everybody. I had an initial provider. I was not comfortable with the care and I switched. And with my new provider, they have a portal. My first provider did not. And I went on the portal and I started reading things that my new provider had dictated into my record, things that I had never seen. Um, there were addendums to reports, addendums to MRIs that I'd had before I started treatment, and I had never seen them. My first provider had never shown them to me or alerted me. So I went back to the portal of the place I had the MRI, and indeed there was a big addendum there that got me a little concerned. And I called them, I spoke to the radiologist, and turns out there's nothing earth shaking. But there were errors in the dictation. And what happens is doctors dictate reports, and they're dictated and interpreted by people who don't always know medicine. For instance, there was a commentary in one of my reports about a possible lesion in my skin. And when I inquired about it, it turned out it was ischium, not my skin. So my word of caution to everybody is it pays to read reports. Don't rely on your physicians who might not share all the data they have with you. If there's a patient portal, go on the portal, look at my documents, read them. If you see foreign things in there, question it. And if you don't understand it, uh, what's in there in medical terms, have somebody read it with you or for you, because I was kind of stunned that my doctors did not share information with me, and that there were mistakes in the reports. that's my words of caution.
Wow. Fantastic. Thank you so much, Dr. Jeff. That is such good advice. Any of the other, we'll come to everybody in a minute, but I want to give preference to our providers or retired providers who are on here. Dr. Jack, Dr. John, anybody I missed, would you like to comment on what Dr. Jeff just said?
This is John. Yeah, I agree. I found a lot of stupid stuff in my notes when they show up on the portal. Not only do you have dictation errors, but there's a lot of cutting and pasting that goes on in the notes that we write. We're trying to conform to Joint Commission, you know, uh, recommendations when we write our notes, and sometimes it's easier to cut a section out of the previous one, and then we end up putting stuff that's not still true. Sometimes there are even words that carry emotional slants to them or opinions in there. So it's not possible ever to have your records changed and there's good reason for that. If something is being investigated, you don't want people changing the records. But it is possible to have addenda put into your record. So if it's important enough to make a change, an addendum can be put onto a doctor's note to make a correction.
Thank you. Thank you very much, Dr. John. Before I go to Jeff Marchi, did you want to comment, Dr. Jack?
Nothing to add. Nada, no más.
No más? You're good,
No,
Jack.
no más.
No más. Okay. No más, no más. Okay, the floor's yours, Jeff Marchi.
Well, just to reinforce what was just said, when I had my PSMA PET scan, it showed that I had cancer in my prostate bed. And that's what it said. And Dr. Hartstark thought that was true. But I spoke to a urologist whose husband's a GU oncologist. She says, this just doesn't sound right to me. And she went back to the radiology oncologist, and sure enough, they had misread what he said, and that wasn't true at all. And he put an addendum in saying that there was no cancer in that area. So, like they say, watch out what they're telling you. It may not be true.
I got a question, Jeff. I know this is America and not Italy, but what's the actual pronunciation of your last name?
Markey.
That's what I thought. Okay.
If my fratello Len Sierra was here, he would have told you that too. But I remember that I think I remember that from when I did my year of Italian, but I'm not sure. Maybe I didn't. Maybe I don't. So, anyone else like to comment on this medical records issue? We don't talk about it very often, and I think it's a fantastic issue to bring up. Anybody have any other input on the medical records issue? Yes, Larry Fish.
Likewise, my father died from pancreatic cancer, but my medical record said that I previously had pancreatic cancer.
Oh, wow.
Quite a
Wow.
shock to find. So, just one more example of that.
Yes, Dr. Jeff.
Yeah, so the way these medical records actually work is there are pre pre kind of printed things lists that doctors go down. For instance, there's a box that says seminal vesicles, no disease, or seminal vesicles, normal. In my case, I had disease in my seminal vesicle, but they checked off, they wrote disease spread to seminal vesicle, but then they checked off the box, normal seminal vesicle. So people get careless. They go down lists. Uh, they don't pay close attention. I could tell you another quick one. Many men get put on finasteride. Well, if you have a uh, a PSA on finasteride, you really have to double the value. If you get a 5, it's really a 10. And I had a 9.82 and they wrote on finasteride. Well, I wasn't on finasteride. So I can tell you, and I've been in medicine 48 years, people are sloppy. They don't pay attention, and wrong data gets put in our records that then if you change providers, they read it and they think you have something that's incorrect. Um, I'll offer this. If anybody reads their medical records and is confused by it, I'll be happy to look at it with you and hopefully unconfuse you.
Thank you, Dr. Jeff. Thank you. So, are you suggesting, especially for some of our people that have been in treatment for quite a long time, that they should ask for a full set of their medical records to review?
Well, I
What?
think if there's any doubts, Rick, I think if there's any doubts or any questions that of things that don't seem exactly correct, yeah, um, I would go on the portal and try to read, because now every note that after you see the provider, they dictate the note of your visit with data into the portal. It's part of the documents that you're entitled to read and copy.
I just want to say that it's not just the doctors who are a little careless in terms of how they edit their notes. Um, I am permanently guilty. As hard as I try when I send out my reminders, I do know this week I repeated one item twice, and I apologize for that. Uh, Usually it's because it's late on a Friday and I want to get done and I just want to get done with it. I do read it through, but I bet you there's not a week that it comes through without some sort of a typo in it. So I'm sorry about it. And just a shout out to Richard Stanton, who caught an agonist that should have been an antagonist the other week. And when he pointed it out to me, and he was absolutely right. So I have some empathy for these doctors that are doing a lot of dictating, but unfortunately, the difference is that when they make a mistake, the consequences can be a lot more serious than when I make a mistake. Okay, moving right along, we're going to Henry. Henry, how's life in South Carolina? Henry, you there? Come in, Henry. I can see that your microphone is on. I know you're on the phone. So
Yeah, can you hear me?
Oh,
Can
yeah,
you hear
now
me?
we can hear you. Yes, sir.
Life is life is warm in South Carolina. Very hot.
It's okay. It's warm
Very hot.
it's warm here too. Go ahead. What's on your mind tonight?
I've been getting consistent PSA readings. I'm slightly detectable, still at 0.07, and I'm told that a PSA would not detect anything if I went to get a PSMA scan done. Is there anything else I can go get done? Considering that the PSMA won't pick up anything, so I'm told.
So this is a really good question, and and I'd like to get input from the group. This is a situation where Henry has the beginnings of recurrence, but no noted prior metastasis. Is that's correct, right, Henry?
Correct.
And when we first started scanning people like you, we were doing it at around 0.25. And that was sort of around where the trial was done. Well, that's how that trial was done. Over time, we've come to recognize that maybe we should be scanning earlier. And Dr. D'Amico at Dana-Farber, he wrote a paper, a very good paper, saying we should scan earlier around 0.15. At 0.07, I think they're probably right to say no, but at 0.15, we're happy to provide you with the paper from Dr. D'Amico and others, including Dr. Carroll and others, that strongly recommends that you do get tested. As this discussion develops right now, I was going to say I'll put it in the chat window, but you're on the phone, so I can't. But you can reach out to me when you're ready.
Okay.
Let me throw it open for everybody. Who would like to? Anybody want to comment on this?
Let me just say there's no guarantee, as you know, I was tested at 0.1, 0.13, 0.17, whatever it was. I kept pushing up, and I didn't show up positive until I got as high as 0.9. So so many scans, PSMA, Axamin, choline, everything else. I was trying to catch it early. For whatever reason, I was unlucky. Nothing showed up. I wanted to be proactive. I wanted to get the early treatment. Go ahead, radiate my pelvis. Go ahead and radiate my pelvic bed. I want to go for a cure. Unfortunately, that didn't happen. So sometimes you don't have the luck, even if you try and do everything right. And I showed metastatic disease when it came up around, 1.1 something. For whatever it's worth.
Yep. I mean,
this is John. My particular doctor is still using 0.2 as the time to pull the trigger for the PSMA scan. The higher your PSA is, the more sensitive the test becomes. The more, that is to say, the more it's able to detect the cancer if it's there. The lower your PSA is, the better chances you have of getting a false negative. So it's exactly a trade-off.
One more factor, let me just add. I don't know if I ever discussed this before, but there's sort of an inverse relationship between detectability with a low PSA and a high testosterone level. And if you have a very high testosterone level, there's less of a chance of the PSA being correlating with a positive PSMA, and that may be one of the factors that contributed to my PSMA not showing up until I was higher than the usual threshold, because my testosterone was 735. And I did some research finding out there's an inverse relationship there between, so if I had a lower testosterone level, I may have been caught earlier at a lower PSA rather than such a high PSA.
So,
So
I put
Henry presumably has a normal testosterone level.
Whatever that means.
My last reading were not that high, between 300 and 400.
That's very normal.
Okay.
So, I think the bottom line, Henry, is don't get anxious that they won't do it yet. Keep talking
Okay.
to us. Come in at around, let's talk around 0.15. I put the link to the D'Amico paper in the chat window. The good news is that will also go into the recording and on the
Okay.
blog. So you'll also find it on the recording and on the blog. And I actually put the piece that he had in the reading room as opposed to, there's an article as well, but the piece he had in the ASCO reading room was sort of directed at the docs. It was really saying to the other docs, don't wait until 0.2 or 0.25. You may be waiting too long. And
Hmm.
so it's a good thing to show to the guys later on. And the fact is, if you're negative, then you do what Dr. Jack did. You have to repeat it. And sooner or later, we hope we find it. But also remember, there's probably 10 to 15% of men who don't express PSMA.
Right.
And that was one of the papers that somebody, I can't remember whether it was John or Len, but somebody talked about tonight, maybe it was Ben, looking for other markers, if, for PSMA. How do we know if you express PSMA? So, but hang easy, Henry, and we got you.
Okay. Okay.
Amazingly enough, although it's been a long night for those of us who got on before the first session, I've gotten through everybody, but there are some people on here who came in late. So let me ask if any of the following people, Stephen, Gaushan, Bill Lee, Steve, my buddy Dave, if any of you would like time, put your hand up and we'll come to you now. And to put your hand up, most of you know it's the little hand icon in the bottom left. So, Bill Lee would like some time, Stephen would like some time, and Gaoshan would like some time. Okay, let's start off with the first person who got their hand up, who's Bill Lee. Go ahead, Bill.
Mine's real quick. Just some good news today. I had another PSA test, and back in June, I'd gone from 3 down to 0.15. This last time, I'm down to 0.023.
Ooh. And this is as a result of starting hormone therapy, correct?
Correct. It's dual. Lupron, and then last month added Xtandi.
That's good. And the reason it's good is because we know that once you get down to that undetectable level, you're going to have success with hormone therapy. The guys who don't quite get down that low, it's more of a concern. And so it bodes well for you being on hormone therapy. So where were you today? 0.023, did you say?
0.023.
Okay. Okay. Anybody else would like to comment to Bill on that?
Sounds good.
Yeah, I'm sure Dr. Heath is happy with that. Okay. Stephen, you are up next.
Sure. My name is Stephen. I'm in the Atlanta market. I'm new to this group, this chat group. I found you guys through another forum. I just wanted to thank you guys for all being here because I'm just recently diagnosed. I'm at the fork in the road trying to figure out whether I need to look at surgery, radiation. Those are my only two options. They're both good options. Trying to figure that part out. So it's great that you guys were sharing some things I knew, very little about that learning process, trying to get things organized. But Gleason score of 8, I give you all the particulars, but I'm 62 years old, Atlanta market. I know about a center of excellence. I think that's important to me. There's a Dr. Scott Miller here that's in my market that does surgery. I've got a consultation with him coming up next week. So,
let me just say that we would like to give you time, and we will give you time if you come back next week as a new person. We usually put our new men right up front, and we'll ask you about your history. We'll ask you about your background, probably a lot more. You would be in this group only because you're high risk because you're a Gleason 8. So this is an appropriate group for you. And the one thing that you could do as a little bit of homework, and next week's meeting is a Tuesday at 6 p.m. Eastern. And if you have you signed up? Have you signed up to our for a reminder from us?
I have.
Okay, so you'll get a reminder if you check the high risk group. You will get a reminder, and come on in. Make sure you come in the first 10 minutes, and then we will give you priority. What I would like for you to do is to take a look at the Memorial Sloan Kettering nomogram. Have you done that?
I have not.
Okay. So I'm going to put the nomogram in here right now. The link to it in the chat window.
Okay.
Are you comfortable using the chat window?
I am.
Okay. So here it is. And you want to put it. You want to check the pre-surgery nomogram. Fill out all the details. And we love that nomogram. I personally love that nomogram because it really gives you a good feel as to how successful your surgery is going to be. And whether you're going to, what the likelihood is based on the database at Memorial Sloan Kettering, which goes back a long time and of course was pre-PSMA, but still gives you a pretty good feel for whether you're going to need radiation and hormone therapy anyway. And that is, to me, the key issue. I was 56 at diagnosis. My surgeon gave me this nomogram on the first visit. It told me that there was a 70% chance I would need radiation and hormone therapy. And I was all set to do the surgery, and I decided against it because I didn't want to have to go through the surgery and then have to go through radiation and hormone therapy. And there are benefits, but they're not that great. So come back next week. Ben will be moderating, and we'll talk to you about what you found out on that nomogram, and we'll take your whole history. We'll take a detailed history at that time, and we'll talk to you about options in your Atlanta market.
Perfect. Thank you for the suggestion. Thank you guys for being here.
It's our pleasure. It's our pleasure. All right. And Gao Shan, how's life in Panama City, Panama?
Yeah, things are good. No problem. Beautiful blue sky, sunny, warm, so can't complain. I just wanted to say that I'll get my recent PSA results tomorrow, late afternoon, they'll come out, and then I'm going back to US for about 10 days, and I'll just do a double check, another PSA. I also have testosterone, which the last one I did was 6 months ago, and it had gone up to about 400 in February, and my PSA was still 0.001, or no, 002. And on the 15th of July, I'll also get a colonoscopy and then fly back to Panama on the 17th. So hopefully, cross my fingers, everything goes well. And once I get my PSA, Rick, I'll send you an email so you can update the database.
Thank
That's
you.
all.
We don't have Commander Adam in the room today. I love it when we have Panama City, Florida, and Panama City, Panama in the room at the same time. But no Commander Adam tonight. Dr. Jeff, you have a point to make.
Question for you, Rick, about what you talked about a few minutes ago about the validity of the PSMA scan. If an individual gets diagnosed and gets staged with a PSMA scan, and that scan shows activity in the prostate region where the cancer is obviously beginning, and then that person gets treated, radiation, ADT, etc., would it be a correct statement to say that the initial positivity of the PSMA scan would be a valid reality for the life of that person, that they are PSMA productive, their cancer is productive, or do people lose the PSMA antigen after treatment, where the PSMA scan would then not be valid?
Right. In other words, you're wondering whether PSMA can revert.
Yes.
The answer is, first of all, when we scan with PSMA, we're usually scanning to see if it's outside of the gland and not within the gland, because there
Correct.
isn't a lot that shows up, and knowing that it's in the gland isn't that helpful from a PSMA scan.
Correct.
What we do know for sure is that PSMA does revert at late stages when the disease takes on the characteristics of small cell neuroendocrine disease. So men who showed as being PSMA positive extensively, and their disease progresses and they move more into a neuroendocrine-like state, may not show PSMA. But it's sort of right at the other end of the scale. Dr. John, do you want to comment on that?
Yes, I agree with Rick. The capacity to show PSMA on the surface of the cancer cell definitely can be lost over time.
But it's usually in response to many levels of treatment. Many levels of treatment. So.
And then you have the dilemma, Rick, of not knowing whether or not the absence of PSMA on a rescan is indicative of progressive neuroendocrine disease or a response to radiation, which ended up causing, necrosis of the tissue and the diminishment of PSMA. And you don't know which it is sometimes unless you're symptomatic. And it's obviously neuroendocrine rather than,
Yeah. But it's one of these issues, and why whoever presented the paper earlier tonight on trying to test for PSMA, it's really some important research, and nobody knows better than Dr. Jack. I mean, we couldn't figure out if Dr. Jack made PSMA or didn't make PSMA.
Right. And they were on a
So,
hunt and suspicious of me being non-PSMA avid and possibly de novo neuroendocrine, which was scaring the daylights out of me, and I won't say where that came from.
yep, 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 yep. So, all right, gents, it's been a long night. We're still before the witching hour, so anyone have any last? Put your hand up if you got anything remaining you'd like to raise. If not, oh, Larry, I got to teach you how to put your hand up on the machine.
I can figure that out.
Okay, but that's okay. Oh, there he did. Go ahead, Mr. Fish.
Okay, now how do I put it down?
I took care of that.
All right. In a larger sense, don't you feel, especially docs and people in medicine, that the body is constantly facing threats uh, and damage to cells that are probably in hundreds of thousands of potential cancer cells that may or may not develop into a detectable cancer that they may never pick up on. That once they have picked up on some kind of development of a prostate PSMA or another or a metastasis from prostate or prostate cancer, that there's probably a small number of wild type neuroendocrine and other threatening prostate related cancer cells floating in the body. Probably you die before they grow into a number that turns into something that you detect. But they're probably always there in a very small amount. They radiate vertebrae in T6 like I have, and they see diminished, or you're on Lupron or an ADT or radiation for many years. Don't you think that there's always a certain amount of developing cancer that is not going to produce PSMA? It just may never reach that level of being detected, but it's probably already there and always happening. More likely for somebody who hasn't been diagnosed with a significant amount of prostate cancer cells. So it's not surprising that until it reaches a percentage that you can detect. But I would imagine that your body's being threatened, and it's always sort of under attack by the potential of cells that skip the ability to detect. I don't know if doctors feel like that.
I think I'll let Dr. Jack handle that one because it's probably been going through his mind for the
Oh,
last 35 years.
it's not 35. No, 20,
Sorry, 25.
20 no, 21, 20, died in 2003. But it wasn't going through my mind until 5 years ago when the biochemical reoccurrence occurred. And, I was sort of shocked. And as it turned out to be a metastatic situation, I was very shocked. And the only thing I could assume after talking to people, smart people who knew this stuff, is that it was micrometastatic. When I got it originally, I had the surgery, but nobody knew about it. I had a strong immune system, which held it in check all along for 15 years, had a biochemical reoccurrence, and it slowly, indolently crept up to the point where it ended up in my couple of bones and some nodes in my lungs. And, the immune system can hold a lot of things in check when you're young and robust and healthy. And when you're older, all bets are off. So what happened with me, obviously, or maybe not so obviously, was that I ended up very surprised, shocked, to say the least, that after 21 years, here I am with metastatic disease. And never would I have expected it. I was told with my nomogram, and as the years went by, the odds are very low that this would happen. So, it's a wild disease. It really is. I'm sure I'll be shocked to the end. I'd love to be shocked and live to be 90. Then I'd really be shocked.
You,
Thanks. Fine.
you're going
Can
to
I
live
make
to
it
be
five? Rick, can I
90.
make it 5 more years?
You got it, Dr. Jack. I know that. You got it. Your disease moves too slowly. We're, we're all pulling for you.
Thank you, pal.
All right.
Good night. Thank you.
Thank you, everybody, for hanging in. We'll call it a night, and we'll be back next week on Tuesday, 6 o'clock with Ben. And please look out on the sign up for the blog if you want the reminder of the recording. Check the recording, and all the slides will be on there and everything else. And again, a huge, huge shout out to Ben for doing all that work. As well as the work he's going to do to get everything done. We appreciate it. Good night, everybody.
Happy
Thank
4th of
you.
July.
Thank you. Good night.
Good
Oh,
night.
happy
Thank
4th of
you.
July, right. Happy 4th of July.